Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. Hi, my name is Nick Strasser, and I work at Vanderbilt University in Middle Tennessee. You've stumbled on Orthopedic Indications, and this is basically a platform where we are geared towards medical education for the medical sales rep. If this is the first time joining us, make sure you subscribe below. We really appreciate your support. A couple disclaimers. One is this is going to be separate from my work at Vanderbilt, although it is consistent with my interest and excitement about education. And another disclaimer that if you are seeking medical advice, you need to see a physician, orthopedic surgeon, and don't let this substitute for the advice. Certainly, you could build on it, however. In this episode, Jan Schakowsky and I talk through some of the interesting articles from 2023, in particular, pulling out some articles that may make an influence decision-making in the operating room, things such as fibular nails and what their role is, talking about augmentation, pluses and minuses, and whether or not it's used, and then even getting into discussions on total ankle arthroplasty and post-traumatics and different considerations that you may need to think about in planning for these cases. So I think it's an interesting discussion. We hope you tune in, and feel free to leave comments below. I do read them, and make sure you subscribe. So the first one I picked out was, a little bit of a attention grabber, this higher complication rate after nails compared with plate fixation of ankle fractures in patients age 60 years or older. And the reason I selected it is I think a lot of people probably use fibular nails. And I just want to clarify, this is like an intramedullary fibular nail as opposed to a TTC fusion nail. But a lot of times they'll use them in maybe patients with older bone, obviously older bone, but the older patient, osteoporotic bone, maybe not as healthy as skin, with the thought process of a decreased wound complication. And so this is out of Norway. It's a randomized trial, and they had 120 patients, all older than 60, and then they obviously get randomized to be either treated after presenting with this ground level ankle fracture, rotational ankle fracture. They get randomized to be treated either with a fibular nail or a standard plate and screw fixation. Jan, what was your impression on this, kind of just with that background?
Yeah, so I think we're learning more about the fibular nail, and I think when we see some of this right now, we probably don't know exactly when or how we should be doing it. I don't think it's the panacea. Just because you put a nail into something, it's kind of like we've gone through this in the other realms of trauma, that just because you nail something, if it's not reduced, well, it's not going to heal, it's going to fail, and so forth. You're still going to have complications. And I think we're going through that same thing again, that same cycle where like, oh, if I nail it, everything's going to go great. And I think many studies have shown that there's been some people who have, some really well-known surgeons who say that it's not even, a nail is no better than putting a piece of plaster on the ankle. And so I think nails can be very helpful, but there are complications here. And especially in older populations, that's where you're going to see complications of any fixation method, whether it be plates and screws or nails. I wasn't that surprised by this data. There's been a couple studies right now calling into question some of the nails that we've used and so forth. So, my experience is that, when I've seen some of these done, at least that have been referred to me that have failed, it's never been reduced.
Yeah.
And so that's where I have a problem.
Yeah, and to your point, in this particular study, only I think 8 of the fibular nails actually had like either percutaneous or kind of a mini open reduction internal fixation. And I've used it a handful of times, and it caught my attention because I've used it in situations where I'm a little bit concerned about skin or wound healing on top of a plate. And just the importance of I've always had to clamp it and reduce it. I've never been comfortable just leaving it closed. And so, unless it's maybe more of a transverse fracture, maybe then you can get it closed reduced. But it always is a situation where we have to clamp it and reduce it. And again, these, often these times these ankle fractures are occurring kind of that metaphyseal bone. So, you can't rely on the fibular nail to necessarily reduce it for you either, as well. And the interesting thing about this was that they, so just for a quick summary, they looked at their functional outcome scores. And even though there was no difference, you could see here there was definitely a trend towards better function with the plate group as opposed to the nail group. But they did get CT scans on a lot of these patients, and you can see just an example in the bottom right, what that looked like there, where they had that malreduction of the syndesmosis. And I think maybe my point with this was, it's important to reduce the fracture. You still have to reduce the fracture. You can't rely on the fixation to reduce the fracture. And you need some hands-on with the instrumentation, I think, if you're going to use it, because it's not as forgiving to get your trajectory of the syndesmosis screws, syndesmotic fixation. You have to know what that rotation looks like, because you're kind of, once you put the nail in and lock it in at whatever rotation, you're kind of locked at that trajectory. So that can throw you off as well.
Yeah, I wonder, in this case too, the cases that they showed, and just in general, like who's doing these, right? Is it folks who just thought, surgeons who have not had experience, fixing complex ankle fractures? I don't know. I don't think that was the case in this group. But I do wonder if maybe some of these injuries would have been done by somebody else with more experience at times, fixing ankles like syndesmotic injuries. And like you said, that where you put those screws, or if you use like a tight rope or any of those devices, is really determine where the nail ends up.
Yep.
And that's different than a plate. In a plate, you can go around the plate, you can
Yes.
you can drop your hand, you have a lot more degrees of freedom.
Yep.
And I've even had issues with that. Like the first time, I totally forgot about that, and as I'm doing it, I wanted to like drop my hand.
Yes.
I'm like, I can't do that.
Yes. Right.
And I'm super annoyed. And I was like, oh, wait a second, that's right, I'm going through a nail.
Yeah.
You forget about those things when you're used to just plate fixation.
Yeah. And, there's people who use a lot of fibular nails and report some good outcomes, but they use it, I think, on a lot of patients. And so they get used to some of the nuances of it. So I'm not here to trash it. I'm just saying that I think to me, it lends itself to saying, hey, you need to be familiar with the instrumentation. You need to reduce it still. Because if not, you will end up with problems down the road.
And this is one device, even though it seems simple, like it's a fibular nail, right? It's supposed to be a simple ankle fracture, et cetera. I think this is where surgeons really would benefit getting hands-on training.
Yes.
Like in a cadaver lab with the C-arm, put the screws in, play around with it, and then like dissect out the ankle and see where things are.
Yeah.
I think that would be very key in this type of thing. I think just doing your first case on a real patient may not be the best. I think this should be done in a lab. Really, you can learn, and some cases, some tips and tricks for doing these cases.
And you could see how easily it would be for somebody to say, hey, I'm comfortable with nailing stuff. I'm comfortable with ankle fractures. I think it's fine to do. So, we know the situations that you get put into. I think there is definitely a benefit to do that, doing the hands-on treat, because it will add, especially your first couple times, even though you think it's straightforward, it will add time to your case. And you have to be prepared for that mentally as a surgeon anyway. Okay. So moving on, and that kind of lends itself to this case, and this maybe has less application if you're in medical sales, but I thought this was an interesting study. It was out of injury from this past year on splint versus no splint. Jan, are you splinting or are you doing no splint?
Yeah, I splint everybody afterwards, except patients who have already wound issues that I'm worried about. Like I did a TTC nail the other day, and I did not splint them so they could do wound care, because the patient had diabetic foot issues, as well as some blisters. But otherwise, routinely, most of the time, I am routinely splinting these patients.
Yeah, it's interesting. So I'm the same. And for me, my rationale is soft tissue rest. Um, you know, I'm going to say about this paper, it's out of Kuwait. The system there is a little bit different, you know, obviously than here. And they called that out in the discussion where all of these patients were admitted for, I think, 2 days after the surgery. And so I think that is something to factor in, because it's one thing if you go home as an outpatient case and you have to kind of fend for yourself. It's another thing if you're in the hospital, maybe you have a little bit more care. You can make sure you keep it up and elevated. You have somebody kind of reminding you to keep it up and elevated and keep the swelling down. You know, it's a randomized trial. It's about 104 patients, 50 and 50 or 54 and 50 in each group. And basically they looked at wound problems, infection, things like that, and saw no difference between the two groups. Those who had a splint and those did not. But I think you have to take it with a little bit of grain of salt and kind of understanding some of the subtle differences that could happen. But I certainly think the other thing that I thought was interesting in this paper was that almost half of patients who had a splint ended up back in the ER for a splint related complication. That I think is probably a result of, I can't imagine that it's that high for us. Maybe it is, maybe it's not, but I think maybe it's indicating it's easier to get clinical or to get clinic follow-up perhaps in our system. I don't know how you feel about that, Jan.
I think your resident or my resident would be getting a couple of phone calls and maybe a discussion if that was the rate
Yes.
of bring back to the
Yes.
to the hospital. Or, but you know, there are splint complications. I get them, and I think
Yes.
every surgeon does
Yep.
splinter cast. What I do wonder, not only about that, but you know, in terms of splint, like when do you give your patients routinely a boot at some point?
Yeah, usually at 2 weeks after surgery, I will give them a boot.
So I do wonder if, you know, it'd be interesting because I think in the US we do that. I don't know what their protocol is in terms of, you know, when if they use anything like a cam boot and so forth. But what if you did a cam boot versus splint?
I
Um,
think, well, I
and
think that's an interesting
that's fact.
discussion. And you know the case, okay, so Jan, just to tie this all together, you know the situations in which I don't do a boot or a splint is when I use a fibular nail. And my rationale is if I use it and I'm still opening it and clamping it and making sure I can see the reduction um and then fixing it is I want, if I'm going to go, you know, to the trouble of doing an intramedullary device, I want to do it in a way that I can let them use it early, and I want to get them out of the splint early, let them, and so just not have to deal with that hassle. The other situation in which I will go without a splint is if they do kind of like a mini open and slide a plate and, you know, a couple percutaneous incisions to fix it. And that's in the situation where I feel like I can get a really good reduction with just a point-to-point reduction clamp. Yeah, so somebody asked that, what about isolated fibular fractures that you don't use a fibular nail walking boot right away? I think if the syndesmosis isn't involved, Jan, what do you think? Do you let a bimal weight bear right away, or do you like right at 2 weeks, or are you keeping them off it for 6?
No, I wait till 2 weeks and then I usually let them weight bear. Even if they have a syndesmotic injury, there's going to be a couple studies coming out. We don't have all the data from them yet, but I think in many patients it'll be safe. I do worry in obese patients or patients who are diabetic or
Yes,
neuropathic.
that's a
Those
different story.
no.
Yes.
I protect those still. You know, I kind of read them the riot act, so to speak. No matter what fixation they have, if they're diabetic, neuropathic, or obese patients, they get you got to be very careful with those patients because it can go. They don't know when it's going bad.
Yeah. Jan, there's a question regarding fibular nails. Do you feel there's a strong case for the potential benefits of a nail, secondary bone healing, callus formation, considering the tibia absorbs most of the load when walking?
I don't think there is that much of a benefit there because we know that we have multiple studies that show if you just have an isolated ankle, like, I mean, like nothing complex, no bad syndesmotic injury or anything, you can allow patients to weight bear immediately with the plate. Right. We've shown that. So I don't know what the advantage of a nail is, except for like it's done more percutaneous potentially.
Yeah, I guess that's maybe my argument is that if I'm less worried about the skin breakdown over a nail and putting them in a boot right away and letting them walk on it right away, I'm probably feeling a little more comfortable with that just from a skin healing perspective as opposed to stability.
Right. I agree with that. I think with this, the skin makes more sense to me, right? I think if people say that, but for the stability, I'm not sure, especially like I've not been impressed and I'm not, I like fibular nails, so I'm not trying to be totally 100% negative against them.
Yep.
But distal fixation of the nail, right? Like that's just poor cancellous bone. I mean,
Yes.
the gap fixation is good. It's the distal fixation I'm worried about because I'm worried about that if I just use plates and screws as well.
Yes. Yeah. Yeah. What about if you put the plate, if you're doing like a posterior plating for a fibula, does that change how you manage it? If it's right for a buttress plate, you know, that in the posterior fibula, does that change how you manage it?
No, I mean, you mean in terms of, do I put the plate posteriorly?
If you can, if you find yourself putting the plate posteriorly,
So I'm a big fan
maybe
of,
you don't.
I'm a big fan of actually dual plating the fibula. In those cases, I'll put a simple, I'll put like a, 2.4, 2.7 mini frag plate posteriorly, because I think it does bother the peroneal tendons. And I think patients can tolerate the pain from a lateral plate better than irritated tendons, in my opinion. And that's anecdotal. So I'll put like a small mini frag plate posteriorly, and then I'll put like a lateral plate, and then I'm more confident letting them weight bear immediately because I've orthogonal fixation. I've really captured it. But I don't use like locking plates. Those are, I mean, I don't use like a anatomic locking plate.
Yep.
I use like 1/3 tubular plate laterally and something posteriorly.
Okay, that's good. So lots of good, I think, different approaches from different opinions on things. All right, what do you think about this? I threw this in here just to get your reaction. I'm curious if anybody else has seen this pop up on social media. I saw it pop up the other day, and the funny thing about this is it's got to be like 5 or 6 years ago. You know how you get these like random surveys that you fill out for a chance to win Amazon
$1 million, yeah.
And so I filled one out at one point, and it was something about this particular device, this shock absorber. So I just thought it was, I saw it pop up, and I thought, I am interested to get your opinion on something like this in the knee.
So
how do we make one for the ankle? Maybe that's the question.
Right. And I saw this on social media. I saw this on Twitter actually a couple years ago. And then I saw someone posted a case this last weekend on it. Maybe we were looking at the same post.
Probably.
And it was very interesting to see the dichotomy of answers or the response. People were like, oh, wow, this is really interesting. That I'm glad we're making some progress in treating patients without arthroplasty.
Yep.
Or like, what the thinking here. And it was really interesting because it's like they got a lot of data and marketing, like there's no such thing as bad press very quickly with this.
Very quickly. Yeah.
I mean, but I do think what worries me here is and I saw the x-ray, you didn't include it here.
No, I should have, but
it's pretty invasive in terms of like, there's
sticks out.
Three screws of in the femur, I think 3 or 4 screws in the tibia. And it's modular, which is a problem. I think we all like modular things. Okay. Like, we think we can, but we failed. Like modular shoulders have failed, modular elbows and radial heads. Sometimes they're questionable track records depending on the company. Modular hips, horrible, right? They've all been recalled and they break. And so then we put a modular device at the knee, and I don't know. I think we have very good options for knees, like a knee replacement. Or partial knee.
Yeah.
And so this is just, I don't know if any of the folks on the call, if any of them have any experience or are selling this. I mean, if it was smaller or something but like, it just seems like it would aggravate the patient when it was placed medially there.
Yeah. I think, and I'm definitely 100% all for, thinking outside the box and different ways that we can approach things. But I kind of agreed with you. It looked fairly invasive, like it would be more bothersome because it looked, it's a fairly subcutaneous structure depending on the patient habitus, right? And I can understand the sentiment, but you have these patients who are betweeners who are not quite bad enough for a knee replacement, and needing something as kind of a stopgap. And then, but to your point, you worry about something modular in that situation, and you got screws that you're kind of loading in that area. So broken hardware seems inevitable to me because it's being loaded dynamically and it's going to be moving, and you got to get that center of rotation in the right spot. There's a lot of factors, I think, that go into it. So it'll be interesting to see it play out, if it catches traction, or if it's is not as, or maybe it's just a start of something. Who knows? It's just kind of an interesting concept.
Well, how this, what this, I don't know if this is anything related to it, but I remember there was a study when we were residents in Rochester. One of the other residents was doing a study where they were using magnets that were implanted, and the magnets, the opposite force.
I don't remember
yeah.
this.
Yeah, no, I remember this. It was, I think the resident was a year ahead of me. I have no idea where it went, but it's like the reverse of this, but it was using magnets to do the same thing on the medial side of the knee. And I don't know where I don't think it went anywhere because that was 15 years ago. I think we would have heard about it. But I think people have been trying this for a while, to try to, some other MIS like thing to do for knees, because this is very common.
Yeah.
This problem.
Yeah, it's a problem. It's going to be more common too, especially when you talk about,
Ozempic is though going to cure all this. It's going to be fine.
Yeah, exactly. Oh man, that's another podcast. Okay. Kind of an interesting paper. Again, a little bit of attention grabbing, at least for me, Brostrom repair. Are you an augmenter, or do you go without, or do you just go native tissue?
Yeah, this was a big, I don't know, this caught my eye too. So I usually do native tissue. I do use the internal brace. And one, if there's a revision, or two, if someone's like like a real athlete, not like me. Okay. So they have to, if someone's a real athlete, then I'm thinking, okay, maybe I should, tennis players, especially cutting activities, stuff like that. Basketball players, then I think about doing augmenting, but I don't do it often. And I've seen a few patients, knock on wood, maybe because I haven't done enough for them. But maybe they do exist for mine too, where they've been referred to me because they're too tight. Yeah. And they complain about it. And then they come to me for a second opinion. They're like, hey, I had this repair. I don't like it. I can't do the motion. And I'm like, their ankle's just stable. I mean, like, you examine them and you're like, man, this is awesome.
Mm-hmm.
And I think they're just too tight. And they actually were better athletes in a way because they had some flexibility.
Yeah.
I don't know. But how about you? How often are you using these?
I use it quite a bit, and I would say probably more than 75% of 75% of my Brostroms, I'm using augmentation of some sorts. I agree with you. I was a little bit surprised with these. If you look at the results, they had 91 patients, which is a pretty good number to look at for 5-year outcome. And I really pay attention to anything Dr. Clanton produces. He did a nice kind of summary with Dr. Saltzman on the Foot and Ankle International podcast. So you might listen to that if you're at all interested. I think the one thing that kind of stood out to me, though, even though maybe the functional outcomes weren't that different, they rehabbed the augmented patients faster. The rehab protocol was a little bit more aggressive. And the other thing that was really helpful is, and he talks about it in that podcast interview, is talking about tensioning and not over tensioning, to kind of, to your point, with the augmenting with the internal brace. So I thought that was actually pretty insightful from a perspective of like learning what we can do with it in order to get good outcomes. And maybe you could say, that is, those at least, if you augment it, you can move them faster, and they seem to have similar outcomes to those that you use just native tissue. But, just hearing too some of what the forces are, a native tissue repair, I think was like 60 newtons is what he said, and you'd have to fact check that. And augmentation, at least with the internal brace, those numbers are going to be like 250 newtons. So this idea that you can rehab them a little bit quicker because it can kind of stand up to some of that stress a little bit more. And again, to your point, not over tightening these patients, or not over tensioning.
I got a quick question. So you mentioned you use some type of augmentation, and so what else are you using?
Well, I think that the other ones that are out there would be, there's Alloughani has, other options for augmentation. There other.
What are you using? What are you using?
I use an internal brace. I use
Okay,
Arthrex internal brace. Yeah.
I've not used those other devices. I'm not against any of them. I'm just curious what the experience has been for some people. I don't know. Because that would be interesting as well if there was like in a study like this, if they redid it and did it with internal brace, native tissue, internal brace versus some type of artificial like Alloughani, or I don't know. Alloughani's not artificial, but it's bioabsorbable, right?
Yes, but I think it's five years. If anybody from the companies, feel free to drop it in the chat. I believe it's 5 years with the.
I think it's fully synthetic too.
Yes, fully synthetic. That's
fully
right.
synthetic. So it would just be curious to see, like, a clinical study with that, right? If there's something to that, right? If you have the reconstitution of your native tissue, would patients like that better? Or would they never get too tight, for example, because they stretch it out? I don't know. Like I don't think anybody would want to sponsor that, because if it showed one was better than the other, they might get upset. But I do wonder about things like Alloughani in a good way. Like I'm like, wonder if that's a reasonable thing. It gives you that early strength, but over time you don't have to worry about that fiber wire, fiber tape. I know some people think it can cause an inflammatory reaction.
Or even just like stress shielding. Are you shielding the ligaments too much? Because you do need those to heal. We know that when you're fixing a fracture or you're repairing a tendon or ligament, we want the natural tissue to heal in. So this whole concept of stress shielding is kind of interesting to me as well. So but I think the couple things that I've learned through the years is, one is there can be failures no matter what system you're using. Some people just they'll retwist it or whatever, and I just had one last week and it was augmented, and I had to go back and actually do a lateral ligament reconstruction on it, and that's been a rare event. I will say that, a rare event. But one of the things that's been really helpful is, and I don't know if you use X-ray. We had this discussion a couple of weeks ago at a conference I was at. I use X-ray to put my talar fixation in. And I think, I know you don't have to, and I know that there's, people that are very comfortable not using it, but it was so nice to know that when I went to find my new hole and trajectory for my reconstruction, and not that you want to plan out for things, but I've seen situations arise where it's so far off that you just don't have a good place to do any sort of revision surgery down the road. It was very nice to be able to just use that same hole, upsize it a little bit, and then put my graft right into that hole. So I would say, to me, it was a reaffirming, yes, always get a spot film. Just make sure you're in the right spot, even though you can, you have the guides and things to kind of help you, and you can look at the anatomy. It is nice to know that you're going to be centered in the talus. Heaven forbid you had to come back for anything.
I agree 100%. I don't know why people wouldn't. I mean, maybe it's a little bit like faster, but I mean, it doesn't take that much time. And then I feel more confident, doing it, right? Yeah. So I think it's just it's one of the tools we should be using.
Yeah, I think so too. So anyway, it's good.
Reps, anybody's doing, sorry to interrupt, but
no, go ahead.
For the reps, anybody's, with surgeons, whether they're experienced or inexperienced, doesn't really matter. I think, taking that extra shot, we take so many shots in ortho anyways, but one extra shot just to confirm position of any guide wire, whether it be a fibular nail or whether it be, something like the internal brace, I would encourage them to do it, or to tell a surgeon, oh, hey, you want to check a lateral here or something like that. Because we're always like go, 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 and so forth. But I think it could be extremely helpful, and to just, keep everybody out of trouble, because, obviously, you don't want to be associated with something goes bad, and then someone gets upset and frustrated with the product and blaming the product, not necessarily the user of the product.
Yeah. Not that surgeons ever do that. I mean, I know that they're
I've
always
heard
like,
it happen like once.
That
Yeah.
was me. All right. Another one that had a podcast out of FAI that was a good interview. This is Dr. Ellis and Jae-Young Kim. Interesting. Jae-Young is a fellow. This is his research work. And he's a fellow at Baylor, I believe. So just kind of an interesting discussion looking at two cohorts, and this is retrospective, but 178 ankles from 171 patients. And I think they had 60 patients in the post-fracture group, and the rest were in the kind of primary arthritis group. And what they found was that, their scores were pretty similar, but there were a lot more revisions for gutter impingement in patients who had post-fracture ankle arthritis. And I think, and it didn't seem to matter whether it was intra-articular or extra-articular. And I just think it calls to the point that if you're a rep that's working in cases of total ankle arthroplasty, I think these require another level of scrutiny on whether it's your preoperative plan as you prep the case, or maybe even thinking about encouraging folks to take out hardware. I do a lot of hardware removal in a staged fashion so that I can get a good CT scan, so that I don't have to make multiple incisions. But I think maybe just calling out that these can be a little bit of a different animal and have different challenges than a patient that has what I'm going to call primary post-traumatic arthritis, cases in which there's maybe no fracture. It's that instability patient. It's that varus kind of pattern. I don't know. Does this seem to echo what you would say, Jan, for these cases?
Yeah, the one thing I think this is done by a very experienced group, okay, with Scott Ellis, right? I think he does quite a few total ankles and is a very experienced surgeon. Because, there was a small group, but they didn't find any difference between post-traumatic and non-traumatic, like you said, primary. I find that surprising.
Yes.
Because in every other arthroplasty, there's a difference: knee, hip, shoulder, elbow. And not saying there can't be good outcomes after, for post-traumatic arthroplasty, but the fact that they showed no difference, I was like, is that just like a skill of a surgeon? I wonder skill of a surgeon, were these not very bad post-traumatic injuries? I don't know, as a group. Because there's more scar tissue, there's people have different incisions, different hardware, etc. They have a soft tissue injury related to the original injury and fracture and repair. That's why I call it a question. I think it could just be the surgeon here, an experience, because I would when I see a patient and I convert them from post-traumatic total to a post-traumatic arthritis and gave them a total ankle, I am very particular about saying, hey, there's higher risk here. Your ankle's been operated on 6 times. Something can happen now the 7th time, right? Oh, I've never had an infection before. Because there's more scar tissue. I don't know. These take me a lot longer.
Yes.
Post-traumatic ones.
Yes.
And I do the same thing you do. I take out the hardware, and I would recommend everybody, if you're a rep doing total ankles, tell the surgeon to take out the hardware in a stage approach, because
you should just tell them that the plan failed and they have to take the hardware out, and then they can do it. That's what I would do.
And I would just tell them, when you pre-op or whatever, you talk to the I would always encourage, because if a screw is broke, you don't want to be spending time getting out hardware, and then you're like, oh, now I got to go do the real part of the case. Yes. So, I don't know, but I do find this interesting. I would like to see a bigger study, but obviously we're still not doing as many total ankles as we do total hips or knees, right? We'll never get to that number. But I think, I'd like to see more numbers here, because or maybe are they doing something different in this group than me? What can I learn from? What can I take from Is there some other protocol, or I have no idea. Is it a different implant that they use? You know, it's things like that. I'm kind of very curious about this study.
Well, okay, so along those lines, you know, one of the discussion points that came out in that particular interview was Achilles tendon management. You know, open Achilles lengthening, percutaneous Achilles lengthening, gastroc recession. When do you use one versus the other? I mean, how often are you addressing something to the Achilles on a total ankle?
Not all the time, but most of the time.
Yeah, I agree. Yeah.
I just did one the other day, and it's like the first one that I can remember, and I don't do tons of them, so like that's with the caveat, but it's the first one I remember. I didn't touch the Achilles. Like I put everything together, and I'm like, wow. And she had not post-traumatic, but she had just, you know, primary arthritis, and she had an excellent range of motion pre-op. Like it was like shocking with her x-ray how good her range of motion was.
Yeah.
And that was the difference. And she had done physical therapy. Like, you know, the person who referred her to me did like a huge non-op thing for like a few years, like bracing, therapy, injection. And I think she just kept, you know, she did not get contracted, but otherwise I'm doing an Achilles release on.
Yeah.
I think that's the exception she was.
And then, you know, the other thing is addressing the posterior capsule on these. And it seems like you try all these different things to get them moving. And I don't know if I can put my finger on it. And I was a little bit saddened and felt a little bit grateful to hear, you know, Dr. Ellis in the discussion kind of say the same thing. They're just hard to get them moving again. And there's something that happens to the tissues in some of these post-traumatics can be hard to manage. So, yeah, it's there. They can definitely be a challenge. And I think it's just, for me, it was, hey, if you see one of these come up with hardware or something like that, it is, if you can take it out beforehand, do it, because it will make your life much better. And I think it's better for the patient too. It's not just about making your life better. It's ultimately what's right for the patient. But if you can make that case more straightforward for them, I think you, by all means, you do that. Okay, just a couple more. What do you tell patients about metatarsal phalangeal joint arthrodesis? You know, this maybe has less application for those in medical sales, but it was interesting from a perspective of the discussion, and so I thought I would include it.
Yeah, so I really like here that when you look at this article, because it struck me that the first author is a physical therapist.
Yeah.
Which I thought was great, actually.
Yeah.
I think this shows like a very multidisciplinary team. And I know Walton, he was a resident when I was at county. But I think that just brings out like, just because you have a fusion doesn't mean you don't need therapy or something like that, right? It's not a motion sparing, procedure, right? It's emotion eliminating. And so I like that they did that. I think that's really good. Like so it's like almost like I trust this study more.
Yes.
And I don't know. I don't restrict my fusion like for MTP fusions. I don't restrict them at all. Once they heal.
Yes.
And I say I know a couple people who have MTP fusions, who have run marathons afterwards.
Yep.
I don't think that's a typical patient because I don't think the typical patient runs marathons. So. But you can, and I think they can get back to most activities that they want to do. And so I tell them, I'm more restrictive about shoe wear, or, I'm more worried about that after a patient for this, because like, especially for females or anybody who uses a wedge type shoe, they might not like the position where they were fused. But I don't, for physical activity, I think this was a really good study showing that you can get back to a lot of these activities.
Yeah, what I was a little bit struck by is how it kind of shaped out like a bell curve. You had about anywhere from 9% to almost 30% who reported a better like improvement in what they could do.
Yeah.
And then like 67 to 87 were kind of in this like, yeah, I can do about the same as I could do before. And there was, at the most 8.5%, which said that they were able to be less active after the fusion. So, at least gave you something to at least counsel patients on what they can do, because that's a pretty common question to get asked after, when you're talking to them about the preoperative options for their big toe.
Oh, so I got a question. So this might be, for people on the call too. there's been a lot of things that I've seen online now about I think it's called biopoly.
I was going to ask you about this.
And so I'm curious if anybody on the call here is maybe even representing them or is talk or whatever can share anything with it or regarding it. You know, we've always had in the past, there's been arthroplasty after arthroplasty option for MTPs, right? Like for that great toe.
Yep.
And there's also been like Cartiva, right? And Cartiva, I remember it seemed a few years ago it was working, and there was some studies that showed it was good or fine. And then I don't know anybody who really does Cartiva anymore.
Same.
And I never did it, but like I've seen it, and it seemed interesting at the time to me. And oh look, so Brandon just picked up biopoly. So and now I see biopoly, and I'm curious, like, okay, we failed with arthroplasty every time. What are they saying is different about this? Have you heard anything, Nick? Because I can tell you, because I actually emailed the company. I emailed like the CEO on LinkedIn, and they never got back to me.
Oh.
So, and I wasn't trying to bash. I'm actually curious, like,
yeah,
hey,
what's the difference?
Yeah, did we solve this? Because I mean, I would want to wait to hear some data, but I think it's interesting because I know the company's going into other joints too. They're going into the ankle joint talus. They're going to the knee with their implant. It's a different implant, but same technology. And so I'm really curious about this.
Yeah, and I think what I like so much about what you're saying is you're staying curious about it, because, and that's kind of how I feel about it, is that time and time again I keep coming back to MP arthrodesis, and you kind of keep looking around if there's any other options that are going to be available for arthroplasty, and certainly not opposed to it. It's just, it seems like every time you think you've got something like Cartiva, I only did a couple of Cartivas, and they kind of all did about like you would expect. But there certainly seems to be an opportunity there, because it's a common problem. Patients are interested in other alternatives to fusion, and I don't know what will come of it. So
I wonder too, and I have zero experience in this, and even zero experience in the literature, but I've had referrals sometimes for patients who have had like Freiberg's disease, AV of the second metatarsal head.
MP, yeah.
And I wonder if this, because they make it for lesser toes too.
Yes.
And like, there's no good option for that toe, right? There's
right.
at least no great option. So it's like, maybe for that it could work, but like when I see data like this for MTP fusions, it's like kind of hard you got to show me some benefit, and maybe they will. But I wonder, I'm just saying, like, I just remember like all the OITE questions and everything about failed implants in the great toe.
Yeah. The interesting thing, I saw an ad pop up for the biopoly, which was, and it showed a second MP fusion and then showing a second MP arthroplasty. I don't think I've ever done a second MP fusion ever. I've seen it once in like Coughlin's textbook, but honestly, have you ever done a second MP fusion? No, me neither. But
it'll be curious. I like to see how that goes. I'm just saying, and not in a negative way. I'm curious to see if we're going to, hopefully we'll see some clinical data, like well-done studies about it, and not just like I hate to say this, but like, marketing on LinkedIn about it. I really hope we see some clinical studies, because if it's going to be a good option, that'll be great, and it would be a great thing to share with patients.
Well, and it's going to be an uphill battle though too, right? Because you see what happened with Cartiva and how that had some good studies, and so I think even if you had some good studies initially, it's going to take it's going to take more momentum, more evidence to push that into the mainstream. I would think, just with history.
True. Just, I mean, there's a lot of negative history regarding the great toe.
Yeah. Okay. Enough about the big toe. Well, never mind. There's more about the big toe. I thought this was kind of a little bit attention grabbing for me. Does minimally invasive surgery provide better clinical or radiographic outcomes? This is a systematic review This is out of Core from this year. I don't remember which month, but it was basically a systematic review and meta-analysis of randomized controlled trials. I think they had 395 feet that they were included. And really, after putting everything together, it was interesting that when they talked about the results is that they really didn't see any sort of benefit to the minimally invasive surgery over that of open surgery for a hallux valgus deformity. And they had some fairly strong language in some of the summary, including, things such as there was methodologic shortcomings of the source studies in the meta-analysis that would favor or basically bias patients that had been fixed with like an MIS technique. Patients have this impression that, oh, it's minimally invasive, so I'm going to do better. So they were kind of calling out some of the biases, at least the authors of this particular study, and that they talked about given associated learning curves, and we all know that they can be steep, during which patients may be harmed by surgeons who are gaining familiarity with a new technique. We are unable to recommend the minimally invasive approach over traditional methods. And so kind of, I don't know, I just thought I'd get your opinion on it. I think this goes back to kind of the training question and getting hands-on and getting seat time, getting comfortable with it. We do know patients are going to ask for this technique. I think that as it becomes more and more popular, that's going to be something that they're going to want. So we want to be familiar with it and be able to use it, but we also want to be safe for our patients. How do you approach this, Jan?
Yeah, I agree with that. I think this needs you need a lot of training because I was on a AOFAS listening to it. They had like an Ask the Expert, webinar.
Yeah.
And I forgot who the expert is, so I apologize. But
it's probably Dr. Schoen. Or wasn't that
it wasn't. No, I remember him, but so anyways, they were talking about MIS surgery and they specifically had, what could go bad. And it was like basically many of the, not the panelists, but the surgeons brought like cases where they messed up on their own, some of these surgeries, like, they dorsiflexed it too much, they plantar flexed it, they did something. And I think that there's a huge learning curve, and it was interesting. So like the surgeon, who's the surgeon? I can't think of his name right now. He was one of the main people in Paragon before he does the
Dr. Meyerson.
Yeah, Meyerson was on.
Yeah.
That was, and Meyerson he goes, well, what did the patients feel about this? And it was like most of the time, the patients had no idea. Like the surgeon was like, man, this looks like, not good, but the clinical outcome was okay. And they're like, and he said, yeah, because he thought it was a lot with marketing.
Yeah.
You told him it was going to be minimally invasive. You're going to do fine. Yeah. And even though you plantar flexed it a lot, and they would show clinical images as well, like, man, I'm not happy with this. What do I do? And he's like, what's the patient complaining about? Well, they said their shoe maybe needs to be loosened a little bit. He goes, were they mad? No. Okay, well, don't do anything. And I think a lot of it has to do with that. I think some of it, but I think, like you said, you got to get your numbers in, right? I think it takes a lot. And I remember one of the guys who does this, posts a lot on Twitter. Gosh, he's from Boston. He's at Harvard.
Chris Miller.
Chris Miller.
Yeah.
Like, and I've invited him, and he's given a couple talks here, like, at IU, for grand rounds. His fluoro times are crazy.
Oh, really?
Yeah. And he's admitted to this. It's not like he's not like, not anymore. But if you look at his original cases, his fluoro times were huge.
Mm-hmm.
To try to get it perfect. I'm just saying, like, there's always a cost related to it, right? There's a time. It's not as easy as everybody thinks. Like when they show an image of it, something MIS, that might have taken them quite a bit of time or budging, or they got lucky and moved over. But it's not always clear cut. And I think that's for any surgeon's training. I think a lot of the fellowships are really focusing on it, which is awesome. I wish I could do more of it. I'm a very open surgery, except when it comes to the ankle. Anything with the foot, I have to see it. I don't know what else to do. So.
Well, it's funny you mentioned that. So we were just doing the internet that we had the IBRA, the International Bone Research, and Cesar Doneto was one of the speakers, and he got up and he goes, I think we need to have more inclusive language. We all talk about MIS, and we don't know if that's maximally invasive or minimally invasive surgery. So we need to be very clear in the terminology that we use when we talk about what is MIS. And I thought that was a pretty good point, at least. But yes, I think, and the hard part is with the training is it's hard to turn that over. I think to turn that over to somebody that's training to learn that technique. And so figuring out the best ways and applications in which we can do that, whether that's cadaveric or if there's simulations that can be made to help kind of facilitate that. I don't know. I think there's a lot to learn.
Yeah, I think this is where like there's a lot of the training potential is huge. It's like for MIS, right? Like this is where like labs, and I think that's where as companies and reps and so forth, I think this is when you can do education for the surgeons so they become comfortable doing this. I think that's where there's a lot of value add. Take the surgeon to a course or have the course or, bring some expert in to show them how to do things. I think that can be a lot of value add because once you feel comfortable, you're more willing to try this. I think it's very different than an implant. I think I'm more likely to try an implant than a new surgery.
Yeah. Yeah.